So, good morning, all of you. How's it? I thank the icon and the great Kubansi Sabu, who is responsible for this icon year to year. It's not sort of a event. And on the second, we begin with the like of none other than Dr. Sabyasachi Sen. Dr. Sabyasachi Sen is to talk about the bone marrow, introduction to the stem cells, and the topic for the lecture is biomarkers or stem cells in diabetes. As far as diabetes mellitus is concerned, it's an ongoing advancement in the diabetic research. And of late, we have found that diabetes mellitus makes an impact on the bone marrow. And from biomarkers of the stem cells, we will be able to know about diabetic complications which occur in a diabetic patient. The changes in the myeloid cells, etc., are responsible for the inflammation of the vessels and even atherosclerotic plaques. And how do that help a pharmacological modulation of the genetic cells will develop in diabetes complications and its course? That will be discussed by Dr. Sabyasachi Sen. Now, a brief introduction of Dr. Sabyasachi Sen. He happens to be an associate professor, Division of Endocrinology, Diabetes, Department of Medicine, George Washington University, and associate professor, Anatomy Cell Biology, George Washington University. He obtained his medical degree from Calcutta University, that obtained the MRCP Ireland and UK specialist training in endocrinology from UK and Ireland. He continued his doctoral degree training at National University of Ireland on gene therapy of cellular cells. He completed medical and research endocrinology fellowship from National Institute of Health, USA. He's certified in internal medicine and endocrinology and is an associate professor of medicine at George Washington University in Washington, D.C. His laboratory currently has 4 externally funded grants from organizations such as A and H, and he has published more than 25 papers in reputed journals and has been serving as an editorial board member of reputable journals such as Metabolic Syndrome and Stem Cell Research Therapy. Who better Dr. Sabyasachi to be able to talk on the topic? Over to Dr. Sabyasachi, please.
Thank you very much. Can everybody hear me?
Yeah. Yes, sir. Perfect. Perfect, sir.
Okay, awesome. Let me try to share my screen. And can you see my screen?
Yes, sir.
Awesome. Okay, so thank you for the kind introduction, and thank you for having me for inviting me to give the talk. It's almost 10:30 at night in Washington, D.C. right now. So I'm not in a suit and a tie, but I'll try to do the best I can. So I'm actually a professor in the department now, and I've moved from anatomy to biochemistry. And I'm going to give you a journey through of the stem cells in diabetes. This is several years of work. So a quick introduction of my talk today. I'm primarily going to talk about endothelial progenitor cells. These are blood-derived stem cells, and we are going to talk about their role as a regenerative tool and also particularly as a biomarker in diabetes. So just endothelial progenitor cells, as the name suggests, these are progenitor or stem cells obtained from mononuclear fraction in the blood. To put it simply, it's essentially from the white blood cell fraction of the whole blood. Then we sort CD34 positive cells by magnetic bead. So you get a specific type of cells. These also have the vascular marks like VEGF. These are usually in the bone marrow, and as you can see, hematopoietic stem cells over a period of time, depending on the need of the tissue, which is undergoing ischemia, these mobilize, come to the peripheral blood, and then get recruited for vascular regeneration. So initially they would look like circular cells, but over a period of time, they change into a cobble-shaped endothelium cell. Now these have produce a slew of growth factors, and these have the growth factors that are produced obviously gives a anti-apoptotic and pro-proliferative edge when transplanted. These also can move from one compartment of the body to another depending on the need for the body to regenerate. So these are essentially could be a very useful tool for cellular regeneration in situations of heart attack and stroke, which plague our patients all the time. So as I said, morphologically, they look like circular cells at day 0. If you start to culture them over a period of time, they would come together to form a so-called organelle or organoid, which is essentially what we call a colony formation unit. And that essentially tells you that they can form future blood vessels or another organelle. So various investigators have shown that these mobilize, as I told you, and can subsequently assimilate with the host endothelial cell line in a single layer, as is the endothelium, over a period of time. So these are the red cells, which are the endothelial progenitors. They assimilate with the vascular endothelial cells. And this is nothing new. This has been in our realm of medical literature way back in almost 17 years now. And these cells truly have been used in various forms of regeneration. People have tried it to particularly use for remodeling of the heart following ischemia, as has been multiple other cellular therapies. So these are the various human trials. I work with Doug Losordo, who has done multiple studies. And if you look at these studies, these are particularly mostly in patients with angina, critical limb ischemia, and so on. And though there was a fraction of patients with diabetes, these were primarily non-diabetic patients. However, now, as you all know, that diabetes is becoming a worldwide time bomb. And there has been also studies using these cells as a biomarker from way back in 2009, 2004, 7, and 16, where people have shown that not only in humans with type 2 diabetes and type 1 diabetes and in animal models, these cells have an impairment in diabetes. So why don't we use these cells as a biomarker for therapeutic challenges and therapy that we put to our patients? And that's important because we always talk about long-term vascular protective effect of cells. And we all know that we need to manage our patients with cardiovascular risk in the prospective. So the question is, what medications do we use? And do they have cardiovascular benefit at a cellular level beyond a serum-based evidence? And for long-term and predictable endothelial function, we and certain other laboratories around the world have proposed certain cell-based assays, and CD34 seems to be the most investigated cell type. So we look at the cell number, we look at the colony formation units, as we talked about, gene expression of these cells, and migration of these cells so that it can move from the bone marrow to the peripheral tissue site, which is undergoing vascular ischemia or ischemia. Now, the other standard methods that we use on a day-to-day clinical practice is blood pressure, pulse, lipid profile, fasting insulin, adipokines such as adiponectin particularly seems to be quite important to note vascular or endothelial health, inflammatory cytokines, and I'm going to introduce the last portion of it also today briefly, which is the arterial stiffness measures. And I keep talking about the colony formation unit because that has been shown in large clinical trials that it has an inversely proportional to Framingham risk score. So higher the risk score, lower the colony formation units. And these are not unknown. These were in the literature, as I said, almost 17 years back. It's just that we have not focused on a cellular outcome measure for diabetes as we have done for various other endocrine diseases, including thyroid cancer and so on and so forth. And also brachial reactivity. So this has a a positive correlation with brachial reactivity and endothelial progenitor cell. What do we mean by brachial reactivity? In other terms, we talk about flow-mediated dilatation. This is essentially how dilated your vessels can be in response to a hyperemic pressure, which means you inflate the cuff, you produce a intermittent occlusion, and then quick release, which essentially causes a friction between the two layers of the blood vessel, releasing nitric oxide, which subsequently leads to dilatation. And we have known for a while that this dilatation is impaired in diabetes to quite a large extent. So in normal patients, with non-diabetic patients, it would be up to 14, 15 based on millimeter per minute, whereas in diabetes, it's almost half of it. So, and the question is, the medications and the interventions that we throw at our patients, does it make any impact on this vascular function or vascular reactivity, as we call it? The other modality that has been looked at very recently in so-called in this paper, which has non-invasive estimation of aortic stiffness. This was published in Hypertension fairly recently in 2019. As you can see, the gold standard would be to put in a catheter and look at the aortic health, so-called. But you can get very similar information if you look at the velocity of the blood at the carotid and the femoral and look at the differentiation of it. And this seems to have a good agreement with the gold standard of invasive aortic pulse pressure, which we normally call the pulse wave velocity. And this has been recommended in clinical trials in daily practice. And this also can be used to assess certain patients and has what we call in the United States a CPT code, which means you can actually bill patients against that. This has been shown that in patients with heart disease, if you have a higher stiffness, that directly leads to increased blood pressure and causes kidney damage and of course back pressure on to the heart as well. And it looks like a machine like this. It's not a cumbersome machine, fairly simple with a software. It actually can be fairly handy to use. And we have shown and others have shown that there is a direct correlation of stiffness with biophysical parameters and blood biochemistry in type 2 diabetes. So let's now look at some of the medications that we use. Let's start with linagliptin. This is already published. I'm going to go through some of the data that we generated. So this was done in a so-called vascularly compromised diabetes patient, which has known CKD. As you know, linagliptin is a drug which does not need to be dose reduced and can be used almost in all stages of CKD. The patients were at baseline with metformin and or placebo, or insulin and the placebo, or they got linagliptin. This was a short study for 12 weeks. And we showed, this is not unusual, that it had some HbA1c reduction. If you look at CD34 cells that had CD184 positive, which indicates its response to SDF1 alpha, so that it shows it's also its mobility, there's a sharp rise within 6 weeks, as you can see, though it comes down, but never really goes to as low as the placebo. But this rise is kind of important, and this has been, we have been seeing this with other medications as well, that there's a sudden positive response if it actually has to work. We also see a clear improvement in cellular migration in SDF1 alpha, in a Boyden chamber. And we also see certain changes in gene expression between last visit or visit 3 between the placebo and linagliptin. So this is for gene expression of PCAM on the CD34 cells. This is for VEGF, which is a vascular growth factor. And this is von Willebrand's factor, which is a clotting factor, also indicates endothelial health. And as you can see, these gene changes are in a fairly relatively short period, literally 3 months. And as you know, in clinical practice, we hardly see dramatic serum-based changes with these medications, whether they're going to work or not. And this is for the first time we have shown that these actually show a gene changes in a patients with CKD. And as was mentioned in the arterial stiffness, that's where the linagliptin seems to have a direct effect with much more improvement compared to the placebo in both 2 measurements that we do with arterial stiffness, which is called augmentation index, and the pulse wave velocity, which is the gold standard. So the highlights of this study would be that the patients with diabetes with CKD had shown some cellular benefit within a short period of time, but obviously longer studies needs to be done to see how a cohort actually responds to it. But the point is, you can actually use a cellular method along with non-invasive methods like arterial stiffness in a CKD population to show changes in a relatively short period. Let's look at another medication. And I'm sure you have heard in this conference and various others that sodium glucose transporters are one of the best drugs to use in heart failure and so on. And there are various studies to show that it shows improved myocardial structure, reduced myocardial preload and afterload, and so on, and renal function improvements as well. And there are studies such as CANVAS-R, EMPA-REG, which indicates that there is improvement in cardiovascular function with pre-existing CVD abnormalities or defects. So let's see how it pans out at a cellular level. Now, before I go further, I should mention that not all SGLT2s are similar. The basic difference between empagliflozin and canagliflozin is its receptor affinity. In other words, empagliflozin would have much more SGLT2 affinity compared to, say, canagliflozin, which has much less affinity for 2 versus 1. This is a difference ratio of 2,500, whereas 250. So on the other hand, remember SGLT2 does not exist in heart and trachea and small intestine. Its SGLT2 is primarily in the kidney. So if you're looking for a cardiovascular heart effect, should you be choosing a more SGLT2 which has more one effect than the other, though SGLT2 is the primary effect even in canagliflozin. But there are obviously some subtle differences between various molecules. So we used canagliflozin for our study. Again, this was not a long study, as would be most clinical trials. This was a 4-month study, and these were designed short time point studies to be more effective changes, to see more effective change at a cellular level rather than a serum level. So if we see a serum level difference within this period, that's great, but we are hoping to see more a cellular level change. So then there was 15 patients in placebo group and 15 in canagliflozin group. And within 2 months, as you can see, there's a sharp drop in blood pressure. And these p-values that we have shown here is over a period of time. This is not based on either visit 2 or visit 3. There's the entire continuum taken into account. There was a statistical significant difference of systolic blood pressure and also diastolic blood pressure. What was very interesting was adiponectin. Adiponectin, there was a statistically significant increase of canagliflozin compared to placebo. As you can see, it's steadily rising, whereas adiponectin actually drops. Even the first 2 months, it was almost parallel to each other. Again, IL-6, though this did not reach a statistical difference between taking the whole time point into account, there was a clear drop at visit 3 between placebo and canagliflozin, showing that there was less inflammation with canagliflozin. Migration, similar to linagliptin, there was an increase, though this did not reach a statistical difference. CXCR4 did reach a statistical difference. This says DF1 alpha or chemotactic agent receptor. So it actually does respond, the cells respond better with canagliflozin for migration purposes. If you look at the gene expression, I'm not going to go through all of them, but clearly there is an improvement in VEGF, KDR, reactive NOS or endothelial nitric oxide synthase, and PCAM across the board almost. And you can see certain differences. As I told you before, there seems to be some quick changes in certain genes, not in all of them, but as you can see, VEGF receptor, which is KDR, shows a very strong upregulation in canagliflozin. This is a urinary exosome. We wanted to go beyond proteinuria changes because proteinuria, we did not see a difference between placebo and canagliflozin. So we looked at the exosomes, urinary exosomes. Though none of these actually reached a statistical difference in 16 weeks, but you can see that there is a trend in almost all the parameters that we looked at, such as nephrin, podocalcin. These are podocyte-based exosomes. There was a decrease with canagliflozin in almost all of the parameters, more so with nephrin and podocalcin. So again, this is another modality that we're researching further, whether urine-based exosomes, which are again a fairly non-invasive study, could give you a better indicator in patients with nephropathy who don't always show a difference in urine protein level changes. So canagliflozin compared to lina showed a clear improvement of blood pressure within 2 months, robust adiponectin rise, and decrease in IL-6 within 4 months, which we did not see in linagliptin. Migratory improvements were very similar to both, though I would say the migratory differences were also a bit more pronounced in linagliptin. But remember, linagliptin was in a sicker population. It was in a CKD population, which was not the case in canagliflozin cohort. So you have to keep that into account as well. So our canagliflozin paper has already been published as an abstract. We have also, it's under review at Cardiovascular Diabetology. So take-home messages are that these cells could be used as a robust biomarker for diabetic medications. And this way you can individualize a medicine to a particular patient who has the inclination to know whether this medication is actually going to work for me. So the cells are actually important in that way. And it also gives you an assurance of long-term benefit. And this is my place of research, my team, and I'm happy to take any questions. Thank you.